Hi everyone! This video is on frozen embryo transfer. You will most likely have already undergone in vitro fertilization and have embryos frozen awaiting transfer. IVF refers to the medical procedure where the egg is fertilized by sperm outside the body, forming embryos, followed by transfer of the embryo back into the womb. We work as a team. Ultrasound examination, egg collection, and embryo transfer are supervised or performed by subspecialists in reproductive medicine on duty roster. The procedures in IVF include several steps: stimulation of ovaries, egg collection, sperm washing and fertilization of eggs, and embryo transfer. This is the outline of the video contents, and I'll go through each of them one by one. First is on consent on storage of frozen embryos and transfer of frozen embryos. You'll be required to sign some consent forms before the IVF procedure. Regarding the storage of frozen embryos, the frozen embryos can be stored for up to 10 years from the date of freezing. It should be renewed every 2 years, and the notice of renewal must be signed by both the wife and husband and reach the center well before the date of renewal. This is extremely important because in the absence of written notice of renewal, the stored embryos will be discarded. The stored embryos can only be used when you are the parties to a marriage. Upon death of either partner, the stored embryos cannot be used by the surviving spouse to bring about a posthumous child or children. In the consent form, you are required to choose that upon death of either of you, or in the event of divorce or separation, what you want to do with the stored embryos. You can either choose to dispose them, donate them for the treatment of other infertile couples, or donate them for research, quality control, or training. Both the wife and husband have to sign the consent form to transfer frozen embryo in each cycle. There are different types of frozen embryo transfer cycles. Frozen embryo transfer can be done in a natural cycle, letrozole cycle, or hormone replacement cycle. If you have regular menstrual cycles, we advise frozen embryo transfer to be done during natural cycles. If your cycles are irregular, then we can try letrozole to induce ovulation. If you're still not ovulatory despite the use of letrozole, then we can use hormone replacement cycle. There are no difference in pregnancy rate between natural, letrozole, and hormone replacement cycle if you have regular menstrual cycles. However, natural and letrozole cycles are associated with lower obstetric complications, including the risks of hypertensive disorders in pregnancy, preeclampsia, macrosomia, preterm birth, post-term birth, low birth weight, cesarean section, postpartum hemorrhage, placenta abruption, and placenta accreta. In natural or letrozole cycles, you will be asked to attend the clinic for ultrasound to check the size of the growing follicle. When the follicle starts to grow, you will receive blood taking consecutively for a few days to detect the rise in a hormone called LH. It is possible in some cases that the LH surge cannot be detected by daily blood taking. In these cases, a new cycle may be started in the next month, or we will switch you to hormone replacement cycle. In hormone replacement cycles, you will take a female hormone daily, orally for 2 weeks. After that, ultrasound is performed to measure the thickness of the lining of the womb. If the lining reaches at least 7 mm, then you can start oral and vaginal progesterone. Following is some information on embryo quality and thawing of embryos. Embryo quality for day 2 embryos are assessed based on the number of cells and the degree of fragmentation. Grade 1 is the best, whereas grade 5 and 6 embryos are not transferred. Blastocysts can be graded into good quality ones, fair quality ones, and poor quality ones. Generally, good quality blastocysts have higher implantation and live birth rates. Embryos are thawed on the day of embryo transfer after admission. Unfortunately, not all frozen embryos will survive the thawing process. Around 90% of embryos survive after thawing. But if the embryo does not survive, some patients may have no embryo transfer. We have protocols on the number of embryo or blastocysts to be replaced. The embryo formed is then transferred back into the womb using a catheter under transabdominal ultrasound guidance. Generally, we advise transferring only one embryo to reduce the risk of multiple pregnancies. The procedure of embryo transfer is straightforward in most cases, but there can be some possible complications. Embryo transfer is performed under transabdominal guidance. Having a full bladder for the procedure allows us to visualize more clearly, and in some cases can straighten the axis of the womb, making the procedure easier. We cannot see the embryo itself with our eyes without a microscope, but we can see a bright spot after embryo transfer in the womb, which is actually the air bubble and the culture medium containing the embryo. The results are quite similar following frozen embryo transfer. Again, you see a reducing ongoing pregnancy rate and live birth rate as the woman's age increase. The reason why we want to avoid multiple pregnancies, even though we aim at transferring the embryo back into the womb, ectopic pregnancies can occur after embryo transfer. In these cases, the pregnancy is abnormal and further management may be needed. You can also download the photo of your embryo. You will receive instructions on how to download the photo of your embryo after the embryo transfer. Just follow the instructions. The luteal phase support is different in different cycles. After frozen embryo transfer in natural or letrozole cycles, there is no need to use luteal phase support, such as oral progesterone, because there is no luteal phase defect in these cycles. However, if you are using hormone replacement cycles, you must continue all prescribed oral and vaginal drugs. If you are pregnant after embryo transfer, We will perform a pelvic ultrasound when you are 6 weeks and 8 weeks pregnant to confirm that the pregnancy is intrauterine and ongoing. If all goes well, we will refer you for antenatal care. I hope that from this presentation, you can also visit our website for more information. The link is shown in this slide. We also have Facebook and Instagram accounts, and you can visit our page for the latest information. Thank you for listening to this talk. If you have any questions, you can reach us as follows. The phone number is a voicemail most of the time. You can leave a message with your name, Hong Kong ID card, as well as contact number, and our nurse will get back to you.